Hello and welcome. My name is Jennifer Wilson, and today I'll be presenting a research proposal created in collaboration with Hunter Watt and Sean Zumel for GNRS 508A, Research Theory in Advanced Nursing Practice. Our proposal is titled, Utilizing Safety Planning Interventions to Prevent Episodes of Adolescent Self-Harm. The COVID-19 pandemic ushered in a new set of challenges for adolescents in the United States, leading to a mental health crisis as declared by the Surgeon General in 2022. The prevalence of suicidal thinking, behavior, and death continues to grow among adolescents, with over 40% of high school students reporting persistent feelings of sadness or hopelessness. Within the last decade, the percentage of pediatric emergency room visits for self-injury has doubled. Families of children with mental health needs increasingly rely on the ED for crisis care. Despite best efforts, there is an inevitable lag between ED evaluation and outpatient mental health appointments. Suicidal crises have an ebb and flow pattern, and an intervention that assists patients in coping with such crisis is useful, even if the intervention is only used for a brief period of time until the crisis diminishes. Suicidal thoughts tend to subside over time, and therapeutic tools presented in the emergency setting would make it more difficult for patients to act on future thoughts. Not only could these interventions prevent self-harm, but it could potentially prevent return ED visits, decreasing overcrowding, and overall healthcare costs. Our research will evaluate implementation of safety planning interventions, or SPI, in an emergency room setting. Safety planning interventions originated as a component of long-term cognitive behavioral therapy for suicide prevention administered by therapists in an outpatient setting. In controlled trials at outpatient therapy sites, SPI has been shown to be effective in reducing suicidal ideation in both adults and adolescents. While other interventions, such as safety contracts, have been described in literature, the SPI is unique in that it is a systematic and comprehensive approach to maintaining safety in suicidal patients. The goals of SPI focus on utilizing internal coping skills, presenting distracting strategies, and identifying people to provide support. The SPI is considered best practice by the Registry of Suicide Prevention. SPI was also adapted for application in an acute care setting and modified for both children and adolescents. A literature review revealed a lack of therapeutic interventions for pediatric mental health visits to the emergency room. Although clinical practice guidelines have been published for conducting suicide risk assessments, current standards of care do not include providing psychosocial interventions while in the ED. Typically, depressed and suicidal patients are evaluated, and when hospitalization is not indicated, they are provided a referral for outpatient mental health treatment. The referral approach is often disconcerting and adds anxiety upon discharge. According to a large cohort study in 2020, 13.2% of patients visiting the ED for SI returned within 6 months of their initial visit. The large volume of return visits speaks to a gap in emergency room treatment. The SPI was evaluated in an outpatient setting and was proven to reduce suicidal attempts. A small pilot study of hospitalized adolescents revealed 90% of patients used their SPI within the first month of discharge. Another study of emergency provider attitudes towards implementation of SPI found 90% desired more effective methods to prevent suicidality in depressed patients. Clinical application of SPI in real-world emergency settings with adolescents is limited. A number of small pilot studies have been conducted at pediatric acute care settings in Canada and the United States, as previously discussed. However, more research is needed with randomized control trials at large-scale, multi-site emergency rooms to evaluate the effectiveness and feasibility of SPI. Several outstanding questions need to be addressed. First, will emergency setting time constraints prevent clinicians from implementation? Second, are safety plans retained by patients after discharge from the acute care setting? And lastly, will implementation reduce return emergency room visits for self-harm? Our research will address the final questions stated. But first, we will take a more detailed look at the safety planning intervention adapted by the psychologists Stanley and Brown in 2008 for the acute care setting. This slide presents the core components of the adolescent SPI as adapted for the acute care setting. The first step in creating the safety plan involves discussion of the teen's suicidality and education that emotions and behaviors are temporary conditions. Suicidality is a thought that can arise in reaction to an event. It is imperative that the patient understands the concept of triggers as initiating a sequence of events that can escalate to negative self-talk and result in impulsive action. Through identification of personal warning signs, a crisis can be diverted. Common examples of triggers include family conflict, romantic breakups, and physical sensations such as racing thoughts, feeling hot, shaky, or dizzy. The second component involves use of distraction techniques that the teen can use independently and are readily available. These can include exercise, deep breathing, taking a walk, listening to music, or watching a funny movie. The third component involves listing people that they can talk with to get their minds off of these distressing feelings. Attempt to combine individuals with distracting activities. For instance, I can go on a walk with my sister and listen to music. The next step involves the patient identifying people that can lend emotional support. These trusted contacts should be notified in advance of suicidal thoughts. If the patient chooses a peer, they should be advised not to minimize or overreact to the patient's distress. The patient should also identify professional support contacts. This can include personal therapists, counselors, or 24-hour crisis intervention hotlines. The patient and caregivers should then be counseled on temporarily restricting access to lethal means. Storing dangerous items securely when someone is at risk of suicide increases the chance they will survive. It's like holding onto a friend's car keys when they are drinking. To encourage follow-through with this recommendation, facilities can provide families with a lockbox to take home. The reason for living component involves listing future events the teen looks forward to. Common examples can include an outing with friends, such as a party or a dance. Long-term goals can also be included. For instance, a desire to travel, attend college, or start a family. The clinician should advise that all interventions are used in a step-by-step fashion. But the process of creating the safety plan is to be helpful and not an additional source of stress. So allow the patient to modify the plan if necessary. This is an example of the adolescent safety plan taken from childmind.org. The SPI can be delivered by a broad range of clinicians trained to use it, including school counselors, nurses, pediatricians, social workers, mental health clinicians, psychologists, and psychiatrists.
The purpose of this study is to determine if implementation of SPI, safety planning interventions, reduces repeat ED visits due to SI or self-harm in pediatric patients. The objective of this study is to compare rate of return visits to the ED after implementation of SPI versus rate of return visits to the ED after only receiving the standard of care for suicidal ideation. Our hypothesis is that pediatric self-harm in suicidal patients using safety planning interventions are less likely to return to the ED than patients who do not utilize safety planning. The nursing theory used to help guide our research will be based off Hildegard Peplau's theory of interpersonal relations. Peplau is also known as the mother of psychiatric nursing, and her theory of interpersonal relationships highlights the therapeutic nurse-to-patient relationship through utilization of problem-solving techniques to satisfy patient needs throughout the course of a hospitalization. Our proposed study will be a quantitative primary analysis of pediatric patients in multi-site emergency departments for self-harm or SI. A randomized controlled trial was chosen because it is the strongest experimental design to determine the effectiveness of SPI. The safety plan will require the patient to identify the 7 following criteria: warning signs and triggers, coping skills to distract, people for emotional support, professional support, restricted access to lethal means, and reasons for living. A randomized controlled trial was identified as the strongest experimental design, as alternative designs such as observational studies do not garner enough appropriate nor sufficient data to determine the effectiveness of safety planning interventions over the designated time frame. This study is feasible in emergency room settings as the form is simple to complete and requires minimal training for staff to implement. The time frame of this study will be from January 2024 through January 2025, and patients will be reevaluated for repeat ED visits 6 months from the initial ED visit. No ethical concerns have been established at this time, as all patients will still receive the standard of care for suicidal ideations, such as one-to-one sitter and frequent safety checks. The independent variable is the safety planning intervention, and the dependent variable is the rate of return to the ED. Our target population is pediatric patients experiencing a mental health emergency. Regarding accessibility, we will limit the research to multi-site emergency departments in Los Angeles County. The inclusion criteria are pediatric patients with a chief complaint of suicidal ideation and/or self-harm. The patient must be developmentally appropriate enough to complete the safety planning form and identify the 7 necessary criteria in the safety plan. Exclusion criteria will consist of adult patients and patients who are nonverbal nor developmentally appropriate to identify the 7 criteria on the safety planning form. Simple random sampling will be used for the selection of pediatric patients in the ED with the chief complaint of suicidal ideation to receive safety planning. Patients who are not randomly selected to receive SPI will still receive the standard of care for suicidal ideation. This eliminates ethical concerns that patients not receiving treatment, as acute suicidality is still being closely monitored through the use of one-to-one observation, safety checks, and self-harm prevention. If a patient is selected to receive SPI, recruitment to participate in the study will consist of discussions with the legal guardians on the benefit of safety planning in potentially preventing future ED visits for suicidal ideation.
Grouping. The group includes patients under the age of 18 that present to the emergency department or acute setting with signs and symptoms of intentional self-harm. Sampling is done by choosing the patients that are in the ED or acute setting that self-harmed or at risk for self-harm. Only pediatric patients with self-harm or risk for self-harm will be evaluated and must be under the age of 18. All others will be excluded. Each of these patients will receive a safety plan that pertains to individual needs. One potential bias includes some staff that believe that safety plan intervention can be effective versus others that don't feel this plan will be effective. A brief questionnaire was given to providers about their knowledge on safety plan interventions and their beliefs on interventions. For the studies were very randomized, except for one study, the patients were allowed to choose their specific intervention or interventions. Data collection and management. The survey contributed to much of the data collections. Example would be pre, intra, and post surveys for patients as well as providers. Another example of data collection involved the monitor for patient return to emergency services, monitor for rate of self-harm and suicide after interventions, and screen patients for risk factors of suicide and self-harm. And lastly, to monitor patient outcomes of outpatient interventions. Study and measurement. Questionnaires or surveys were very big in each of the studies. Emergency services data, such as patients returning back to the ED, self-harm and suicide incidence, which is new rate of self-harm and suicide after the intervention, and the instruments were based on each individual study. Reliability and validity were both varied based on the idea that the surveys were self-reported data and people may not be always telling the truth. Sensitivity was high. The data was easy to interpret based on the clear goals to reduce suicide and self-harm. This table shows different variables such as sex, age, and race, and its correlation to suicidal events and suicidal attempts. Data analysis. Once study has been completed, then it is time for data analysis. Researchers took data and reviewed it for outcomes of the study. Success of intervention was different among the articles chosen. Examples: survey questionnaire designed for SI and self-harm, data analyzed for improved results after the intervention. Incidence of SI and self-harm after implementation of medication, outpatient treatment, or even both, as well as readmission rates for self-harm and suicide after safety plan intervention. Risk factors associated with pediatric self-harm to be analyzed for early detection and prevention. Human subject protection. Informed consent was achieved prior to the studies. One case study involved a kid and his parents provided informed consent. No names were included in the study besides the one case study. Researchers use informed consent to get patient information to follow up after emergency room visits. It is unclear if names were placed on surveys, and HIPAA was followed. Thank you everyone for listening to our presentation. We hope you have a great day.